Welcome. My name is Rachel Bella Kramer, and I am the Opioid Settlement Coordinator with Chester County Department of Drug and Alcohol Services. I'd like to thank the Chester County Medical Society for providing this virtual venue for us to provide more information relating to substance use disorder. Today's lecture is the first in a series of 4, and they will be held every other Thursday evening through June 20th. Before I introduce tonight's speaker, I would like to let you know that we firmly believe that recovery from substance use disorder is possible, and it's happening every day in Chester County. I would also like to say that in Chester County, you don't necessarily need to mortgage your house or get a second mortgage in order to have substance use treatment. Substance use rehabilitation is available to the uninsured and underinsured at no cost to them or their family. I encourage you to sign up for our newsletter, and we'll post some links to our website and other resources that are available to you in the chat. With that, I'd like to just put out a few ground rule things here. We're going to just hold questions until the end, but if you could actually place them in the chat, I'll be able to give those to Dr. Davis at the end, and we will address questions then. With that, I'd like to just do a brief bio of Dr. Davis. He received his undergraduate degree in electrical engineering from the Pennsylvania State University and his Doctor of Osteopathic Medicine from Southeastern College of Osteopathic Medicine. He had a dual residency in internal medicine and pediatrics, which was completed at the Geisinger Medical Center in Danville, Pennsylvania in 1994, and he is board certified in internal medicine. Dr. Davis has developed and taught both at an undergraduate and graduate level course in addiction and addiction counseling at Millersville University. Having started his practice in primary care, Dr. Davis branched out into treatment of substance use disorder. He has worked both as a clinician and as a medical director in a variety of settings, to include inpatient detoxification, residential and methadone, and outpatient Suboxone clinics. He's currently working in his private substance use disorder treatment practice, and he is a diplomat of the following organizations: the American Board of Preventative Medicine in Addiction Medicine, the American Society of Addiction Medicine, the he's a diplomat of the American Board of Addiction Medicine, as well as the American College of Internal Medicine. And with that, I'd like to turn this over to Dr. Davis for tonight's presentation.
Thank you, Rachel. Hopefully we don't have any technical problems tonight. Thank you for coming and good evening. So as Rachel said, my name is Dr. Christopher Davis. And although I initially started my medical career doing primary care as an internist and pediatrician, for the last 20 years, I've done exclusively addiction medicine in many different settings, as Rachel mentioned, methadone clinics, private practice, inpatient, outpatient services. And I used all forms of medication-assisted treatment to treat addiction. And some of my lectures coming up in the next few weeks will be talking more about medication-assisted treatment. Over the years, our understanding of addiction has evolved. And so there's different models of addiction. And based on the model, that's how we approach people who suffered from substance use disorders. And based on those models, it's how we viewed them and how we treated or didn't treat them. Some of the early models of addiction primarily looked at alcoholism because that was a bigger problem around the turn of the century. And then as some of these models evolved, it started to look more at just substances in general. So I wanted to kind of go through from a historic perspective some of these different models, and I think some of them you'll very quickly see why that model just doesn't work, and therefore why treating the patient using that model would be ineffective. So the first model is what's called the impaired model. So with this model, the alcoholic was considered hopeless. He was the town drunk. He spent his entire life drinking and wreaking havoc to his life and everyone who was close to him. It was not considered a disease, so there was no treatment. So sort of the classic example of that, if you remember the old black and white TV show with Andy Griffith, Mayberry RFD, and they had Otis, the town drunk, and Otis would go out at night and he would get intoxicated. And instead of just getting arrested for public drunkenness, they just left the cell door open and he would stagger in and he would come into the cell and he would sleep it off and then go home to his family afterwards. So it wasn't viewed as any kind of disease. It was just viewed as, well, there's nothing you can do about it. He's the town drunk and that's the role he plays and there's nothing available for him. Then there's a next model is called the dry moral model. So in this model, alcoholism is due to having poor morals. Alcohol was felt to be immoral, and when the alcoholic was sober or dry, he made an immoral decision to drink because alcohol's immoral and drinking is immoral. His only hope was to get him to go to his only hope was to get him to admit to his sins, become one with the moral community, and to go to church. Now, this was all rooted in the temperance movement, which was in the late 1800s and early 1900s. And actually, the temperance movement had such a strong pull that it played a big role in the initiation of prohibition. So viewing with this model, the person's just immoral, makes an immoral decision to drink. Then we have the wet moral model. So this is the model that actually most people who are uneducated on addiction believe in today, even though it's a very old model. In this model, it's felt that the alcoholic just needs to start drinking responsibly. When they drink, meaning they're wet, they make an immoral decision to keep drinking as if it's a free choice. Abstinence was considered the cop-out and responsible drinking was the goal. And if you've worked with people with the disease of alcoholism, you know that responsible drinking is really not an option. The psychoanalytic model. So around the 1940s and 50s, psychiatrists and psychologists began treating the majority of alcoholics and addicts. Their approach was a psychoanalytic model. They felt that addiction was a result of some underlying neuroses or psychological problem or some unresolved issue. Therefore, treatment was geared at discussing their past and current problems and not on obtaining abstinence. And actually, later research showed that treating patients with this model actually worsened the addiction. Because what happens is, if you're not focusing on abstinence and you're delving into any past or current problems, which maybe they don't even have any past trauma or past issues. But if you're delving into that, the only coping mechanism that they have is to drink more. So you can actually harm the patient by taking this approach. The social model. This model states that people become alcoholics or addicts because they just hang out with the wrong people, the wrong crowd. If the addicted person would just get new friends, they would stop drinking or using. This model, though, doesn't explain why some experiment with drugs or alcohol, perhaps because they hang out with the wrong crowd, but become addicted, but many never do become addicted. So I don't think it really tells the story. The family model. This model believes that the cause of addiction is family dysfunction. There's a complex interplay between the alcoholic or addict and the family members. The alcoholic or addict is sort of selected for their role, and the other family members enable his or her ongoing use. So since it's felt that the cause of addiction with this model is the family, treatment is geared at fixing the family. Now, as I go through these, you might find there's little bits and pieces of each of these models that might be true, but the whole model in general is not accurate. So when they mention that the family members may enable ongoing use, we do see that. But the primary problem isn't the family, it's the person with the disease. The old medical model. This is basically what I got in medical school back in the late 80s. So with the old medical model, the belief with this model is that alcoholism is a severely debilitating condition, which is potentially fatal and contributes to many complications. Sure, I'll buy that. Alcoholism is caused by excessive alcohol use. Now, that's an incorrect statement because that implies anybody who drinks too much becomes alcoholic. Loss of control from alcohol causes deterioration of the organs, which results in interference with the body's ability to tolerate alcohol. Okay, I could buy part of that. But one of the problems with this model is it implies anyone who drinks too much will become alcoholic. The reality is only those who are genetically predisposed to alcoholism will become alcoholic. Drinking too much doesn't cause alcoholism. Alcoholism leads to drinking too much. So when I was in medical school, we learned to recognize alcoholism. We learned to treat all the medical complications of alcoholism, congestive heart failure, cirrhosis of the liver, and so on. But we really never learned how to treat the person who suffered from the disease. And then we moved on to more modern times, the new disease model. So in the 1970s and 80s, a new era of specialty, which would be addiction medicine, developed. Rehabs began to open and approach the problem as a disease. Science was accumulating more and more evidence that addiction is a physiologic disease. I'm not saying psychological, a physiologic disease. Family studies suggested there's genetic factors that cause alcoholism and addiction. Genes are now being identified that cause addiction. Let me give an example. So there was a lot of early research in addiction, or specifically alcoholism, in twin studies. And what they found is if you had two identical twins, so they have the same DNA, the same genes, and they were born to parents who had alcoholism, if the one child grew up with the parents, but the other one was adopted and grew up in a non-drinking environment, their outcomes were essentially the same. The one that grew up in the household with the biological mom and dad with alcoholism, 98% of them developed the disease of alcoholism. However, the identical twin that grew up elsewhere was 11 times more likely to develop alcoholism than the general population. And but what was different with that group that was adopted is a later onset of their alcoholism. So environment may play a role in the time of onset and the progression of the disease, but it doesn't cause a disease. So the disease model states that alcoholism and chemical dependency is a primary chronic and progressive disease that has a tendency to relapse and is potentially fatal if not treated. It's a physiologic disease that's onset, rate of progression are affected by those psychological, social, and environmental factors. So we can't ignore those psychological, social, and environmental factors. They play a role, but they're not the cause. So if you take that disease model and you add in those psychological, social, environmental factors, you get to what we pretty much use now, the biopsychosocial model. So a refinement of the medical model. So it really still recognizes everything the medical model recognizes. So it's a refinement of the medical model that recognizes addiction as a brain disease, with genetics being the biggest risk factor, but external factors such as the environment, people, places, things, and psychological factors affect the onset of the disease and the rate of its progression. So if we're going to call addiction a disease, what is a disease? Well, for something to be a disease, it has to have a target organ that's involved, and there's a defect within that organ. Now, the cause of that defect may or may not be known. As a result, there's definable symptoms of this disease and a predictable course of progression. So let's just pick a couple diseases. So if we look at type 1 or juvenile onset diabetes, the target organ is the pancreas. The defect is loss of the islet cells, which are the insulin-producing cells. Now, the cause of that is still kind of under investigation and dispute. So, this is something we can't say definitively what the cause is, but it doesn't matter. You don't have to know the cause for it to be a disease. What are the definable symptoms of juvenile onset diabetes? Elevation in blood sugar, polyuria, polydipsia, lactic or ketoacidosis, coma, and the predictable course of this disease, if untreated, is death. That they go into diabetic or ketoacidosis, and if that's not treated, they will expire. Pick another disease, liver cancer. So the target organ would be the liver. The defect is there's cells in those livers, in that liver, that has mutated their DNA and have become cancerous, and they continue to replicate. And so the growth of those tumor cells isn't stopped. Symptoms of liver cancer, jaundice, liver pain, coagulopathy, so on, and predictable course, metastasis, and ultimately death if not treated. What about addiction? The target organ is the brain. The defect is an abnormal response of the reward pathway in the brain to substance use. And we'll certainly be going into that in much more detail. Definable symptoms. Well, the symptoms generally are the behavioral symptoms we see. Criminal activity, DUIs, family problems, social problems, incarceration, and so on, mostly behavioral. Now, you do see some physiologic stuff as well, and tolerance and withdrawal, which we'll talk about today. And the predictable course of addiction, if untreated, frequently does end in death as well. What they say in AA is jails, institution, and death. So to really understand addiction, we really have to look at the neurobiology of the brain. So that's what we're going to start to talk about now. And I'm going to need my cursor here. You can see it moving around. So our brain is made up of about 100 billion neurons. And each of those 100 billion neurons may connect with another 100 to 1,000 different neurons. They communicate with each other. It's a whole neural network. So 100 billion neurons, maybe each one connects to 100 to 1,000 different neurons. You can see the number of connections in the brain is staggering. So this is if you look at my cursor here, this is a neuron, cell body here, and it has this wire called an axon, and that wire then connects to another neuron, and that area right where they connect is called a synapse. They don't actually physically touch. When this first neuron wants to send a message to the second, it sends an electrical signal down that wire, and then a chemical messenger is released and binds to a very specific receptor on the next neuron, and then a chemical message has been passed on. So it's electrical and chemical transmission. So the neuron sends an electrical signal down its axon. At the end of the axon, a chemical messenger is released into that little gap, that synapse. That chemical messenger then binds to a specific receptor on the receiving neuron, and these chemical messengers are called neurotransmitters. So we have many different neurotransmitters. We'll be talking a lot about dopamine today, but you have dopamine and acetylcholine and GABA, gamma aminobutyric acid, and you have endocannabinoids, and you have endorphins, and so on. And each one plays a different role in different parts of the brain. We'll get into a couple of them today. So here's a simplistic view of the brain. So we have down low in the brain our reward pathway. You can call it the limbic system or the midbrain. And it connects up here to our prefrontal cortex, which I'll call the frontal lobe as well. So if you look at the midbrain, we have an area called VTA, ventral tegmental area, another area called the nucleus accumbens. That's our pleasure center right there. So let's look at that in more detail. So here's my sort of simplistic drawing of that midbrain or reward pathway. So the ventral tegmental area within that reward pathway is a cluster of neurons that are dopamine producing neurons. And they have receptors for all the substances that we can develop addiction to. So alcohol will bind to alcohol, benzodiazepines, and barbiturates will bind to GABA receptors. The whole reason we have these receptors that addicting drugs can bind to is because we have our own neurotransmitters that would normally bind there. So alcohol, benzodiazepines, barbiturates will all bind to those GABA receptors. THC binds to the endocannabinoid receptors. Opioids bind to the mu opioid receptor. So we have these receptors, these dopamine producing cells. That ventral tegmental area connects to the nucleus accumbens. We'll talk about that. So that's basically the reward pathway. But the nucleus accumbens has some extension out to the amygdala, which is our emotion center, and a lot of emotional memories and euphoric recall are stored in there. And it also connects to our prefrontal cortex or our frontal lobe, which is basically our thinking area. Okay, so most addicting drugs bind to receptors on the neurons of the ventral tegmental area. The axons of that ventral tegmental area connect to the nucleus accumbens, the pleasure center. Drug or alcohol use results in the release of dopamine, which is our pleasure hormone, the neurotransmitter. So the release of dopamine into the nucleus accumbens, resulting in euphoria. It appears that the amount of release of dopamine with substance use is genetically mediated. So if a average person who has no history of a substance use disorder, no family history of a substance use disorder, has a drink, they'll get a little bit of dopamine release. If a person with an alcohol dependency, or perhaps someone who's genetically at risk of developing alcohol dependency, has a drink, they'll get a much larger surge of dopamine than the average person. So alcohol becomes much more rewarding to them. The nucleus accumbens has neurons that extend to the prefrontal cortex and the emotion center, the amygdala. Okay, so let's look at this nucleus accumbens, the pleasure area. So why do we even have a reward pathway in our brain? Because with people who are predisposed to addiction, it seems to cause a lot of problems. Well, the reward pathway, which is at a subconscious level, is placed in our brain to drive our behaviors to do what is essential for survival. So the normal things that would activate that reward pathway would be eating and drinking, physical activity, and sex. And if we don't do those things, we won't survive as an individual, we won't survive as a species. So that reward pathway drives us to do things to keep us alive. Addicting drugs override the pleasure center, creating tremendous release of dopamine in the nucleus accumbens. And at that point, as addiction progresses, sex, food, drinking becomes less important to the brain compared to substance use. The amount of dopamine released during using certain drugs, as I mentioned, is partly genetically mediated. So people may be born set up for future addiction. The alcoholic has a greater release of dopamine when they ingest alcohol compared to the non-alcoholic. The opiate addict has a greater release of dopamine when they use opiates compared to the non-addicted person. So we got that ventral tegmental area releasing dopamine to the nucleus accumbens. And right up here, we have that amygdala. So the nucleus accumbens connects to the amygdala. The amygdala is the area in the brain where emotional memories are stored and plays a major role in fear, a major role in the fight or flight response. Now, some early studies looking at that amygdala would take a lab animal, say a kitty cat. And if you put an electrode in the amygdala of a kitty cat and you give it a little juice, you stimulate that amygdala, that cat will go into the fight or flight response. So it'll bare its teeth, its claws will come out, its hair on the back of its neck will stand. Now that cat has no conscious awareness of why it's all upset, because this is all happening down at the subconscious level of the brain. It just knows it's in fight or flight response, no understanding why. Individuals who have PTSD and panic disorder seem to have abnormal activity in the amygdala as well. And pleasureful memories of substance use, we call that euphoric recall, is partly stored in that amygdala. And we'll talk a little bit more about that as well. But there are certainly things that are environmental triggers for people who are either in addiction or in recovery. And those things are sort of ingrained in their brain, in the amygdala, through a neurotransmitter called glutamic acid or glutamate. So we got this reward pathway here. We got that emotion center. Oh, one other thing I want to say about the emotion center. When somebody has an addiction, they go into treatment, they go into detox, or now maybe a few weeks into residential treatment, you may find that those patients are very emotional. They're emotionally deregulated. Why? Well, they no longer have a nucleus accumbens that's being flooded with dopamine from substance use. So there's nothing controlling that amygdala anymore. So these patients are all over the place. They're emotionally labile, they're angry, they're fearful, they're upset, they're crying. It's now because that amygdala is not in check anymore. So this nucleus accumbens also connects to our prefrontal cortex or our frontal lobe. So what is our frontal lobe? Well, that's what makes us human. That the things that our frontal lobe does is judgment, insight, reasoning, problem solving, seeing consequences of our action, and impulse control. So if you've worked with people with addiction who perhaps are in very early recovery, and you think about, okay, judgment, insight, reasoning, problem solving, consequences, impulse control, you're thinking, but my patients have none of those skills. And that's exactly right. As we'll talk about in a minute, that prefrontal cortex functionally gets shut down as a result of the reward pathway being overstimulated through substance use. So why do addicts and alcoholics make bad decisions? As addiction progresses, the frontal lobe is suppressed by the reward pathway. So the ability to make good choices and see consequences of behaviors is now impaired. So addiction's not a choice. It's a neurobiologic condition resulting in loss of an ability to make good choices. So just some examples of impaired prefrontal cortex with addiction. So in patients who are acutely intoxicated with alcohol, at that point, there's suppression of the frontal lobe. 65% of domestic violence cases involves alcohol use by one or both parties involved. 65%. There's something there. Think of this hypothetical example. I say hypothetical, but I've seen all these. The addicted person having only 2 days left in rehab and is court ordered for treatment, then walks out of treatment against medical advice, which results in incarceration. I mean, I just saw this 3 weeks ago in a patient. The addicted person is told by his probation officer, if he has one more positive urine, he's going to go to jail. Then he uses again the day before, he sees his PO the following week. Now you might be thinking, well, how dumb is that? Like, why would they do that when they know they're going to be drug tested and they're going to go to jail? Why they do that? Because they can't see the consequences of that. They are being driven by that reward pathway. This isn't working anymore. So do we have any evidence that there's a functional shutdown or diminished activity of the prefrontal cortex in people with addiction? Yeah, there's plenty of research. So this looks at the brain of a controlled person and a person with a chronic cocaine addiction. And this is a PET scan. So it's one way to look at the brain and see active areas of the brain. So the more active areas, the parts of the brain that are doing more will show up as reds and yellows and oranges. And the less active areas will be these kind of blues and purples. So you look at this control person. So this here is your prefrontal cortex. And you can see there's lots of reds there. Lots of yellows, lots of reds. So that prefrontal cortex is doing something. Don't know what it's doing at that moment, but it's functional. You look at the person with a chronic cocaine addiction. Where'd all the reds go? The prefrontal cortex is functionally shut down. You can look at the brain function with other techniques, such as functional MRIs instead of just PET scans. So just another way to see what part of the brains are very active. So here's a control patient, and you can see there's the prefrontal cortex right there. It's lots of yellows and some reds. And then you look at the chronic cocaine user, their prefrontal cortex, There's not a lot going on there. This is not the person you're going to ask advice for. They can't make good decisions. They can't see consequences of their actions. They have limited impulse control. Now, there was some early research looking at, well, what part of the brain is addiction rooted in? You know, if we're going to call it a brain disease, well, what part of the brain is malfunctioning, or where's this all coming from? So some of this early research would take a lab animal, either a mouse or a rat, and some of them, they would put a catheter in that would go right into the prefrontal cortex. And if they pressed a button, it would administer cocaine into the prefrontal cortex. Other ones had a catheter that was placed in the midbrain, so around the reward pathway. If they pressed a button, cocaine would be administered right there to the reward pathway. So the mice or the rats were trained to press this level to self-administer cocaine directly to one part of the brain or the other. So what did they find? So the mice that could self-administer cocaine to the prefrontal cortex, the thinking area, did not change their behaviors. They continued to socialize with other mice. They continued to eat and drink. They continued to take care of all their mice little babies. So you just didn't see behavioral changes there. The mice that had that catheter inserted into the limbic system or reward pathway, what happened with them is they compulsively pressed that lever to self-administer cocaine into that reward pathway. They continued to do that to the point of dehydration and death. Dehydration, starvation, and death. So at that point, their reward pathway viewed the cocaine as more essential to life than eating or drinking. So this kind of research confirms that it's that limbic system, that reward pathway, not the prefrontal cortex, that's the root of addiction. However, we judge people with addiction based on the behaviors they have that come from an impaired prefrontal cortex. But remember, that prefrontal cortex has been shut down by that reward pathway. You know, mice don't come from bad homes. You don't have sociopathic mice. Mice don't really have morals as far as we know. So why would we say the mice continued the cocaine use in the limbic system to death and say that, but in people, their use is because of bad morals? Nah, I can't buy that. So their midbrain viewed cocaine as more essential for survival than everything else. So similar things are seen in humans with addiction. When addicted, they give up everything. They give up their jobs. They give up their education, their family, their children. They give up their social responsibilities for ongoing use. They're being driven by that reward pathway. So I want to throw out sort of a hypothetical example here of a brain that's in dire need. So imagine that you were in a desert and you haven't drank in like 5 days. So you are dying of dehydration. And I come up to you and I offer you water, but I offer you water under one condition. If I give you the water, you have to give up your children, you have to give up your family, you have to give up your job, basically everything that's important to you. You would physiologically have to take that water. The midbrain is now in control. So in these times of dire need, the prefrontal cortex has been shut down and the reward pathway is in control. So you would give up your family, you would give up your children for that water. However, after you've hydrated, would come all the remorse, the regrets of what you just gave up, and the attempts to renegotiate those terms. So times of dire need looks a lot like addiction because it's limbic system driven, not prefrontal cortex driven. I want to cover an interesting study. And I knew about this study for many years, but it really wasn't until preparing this lecture that I kind of dived into the nuts and bolts of it. So we used to use the DSM-4 criteria for people with what we now call substance use disorder. And the DSM-4 criteria had two separate entities. It had substance abuse and substance dependency, which we can look at the dependency as those are the ones that have the disease of addiction. So like two separate entities. Now we're going to go into much more detail of the DSM-4 and the DSM-5 towards the end of the talk. So for right now, we look at DSM-4 abuse or misuse of substances, and dependency, the disease of addiction. So there are some people that can use drugs or alcohol for a long time and then just quit. And you're wondering, well, how in the world did they do that? Well, they didn't have the disease of addiction. That's not addiction. That would be somebody we might say had a substance abuse issue. So a good example to demonstrate this was, we'll look at here in a second, it was looking at heroin using veterans during the Vietnam War. So some of these numbers might kind of be interesting. So this study looked at heroin using veterans during the Vietnam War. It was published by Lee Robin in the journal Addiction. So Dr. Robin looked at almost 14,000 enlisted Army men. And these numbers are a little staggering. And when you looked at those enlisted men in Vietnam, 34% of those soldiers were using heroin. So that's a third of the soldiers were using heroin, and 20% of them had physiologic dependency requiring detoxification before they were allowed to return to the state. So back then, the military recognized, hey, we got a big heroin problem here. We've pulled out of Vietnam. We're sending our soldiers back home. We need to do something here. So they did what was called Operation Golden Flow, kind of funny name. Basically, it meant that the soldier had to produce a negative urine for heroin before they were allowed to return to the States. And if they couldn't do that, they had to get treatment. And once treatment was over, they could return to the States. So we've got these 14,000 people in this study, 34% who were using heroin, 20% with physiologic dependency. You eventually send them all home. So 1 year after returning back to the United States, only 10% had any heroin use, and only 1% had addictive use of heroin. These are the ones that probably had the disease of addiction, that 1 to 10%. They had the disease. They get back to the country, they continued use. The other 90 to 99% didn't have the disease, but had substance abuse while in Vietnam as a result of that particular environment, stress-involved environment, obviously, and psychological factors. And once those factors were removed, meaning they returned to the US, there was no longer a compulsion to continue to use. Compulsion's a big part of addiction. Now, compare these numbers to rehab patients who then get out and relapse. So we're saying here in this population, only 1 to 10% had use once they returned to the United States. If you look at patients that go into residential treatment, at that point, by the time you've gone into residential treatment, you've sort of selected out that these probably are all those that have the disease, like people that just maybe drank too much, but could have stopped. They generally aren't ending up in residential treatment. So you got patients that go into rehab, they get out. What's the relapse rate? 70% of those coming out of rehab will relapse within the first year. 70% relapse rate within a year, the majority of those in the first 90 days. Wow, those numbers are much huger, 70% relapse compared to a 1 to 10% relapse. So I think this study of the Vietnam vets really shows that substance use in itself is not the disease of addiction. In fact, most of them didn't have the disease of addiction because most of them didn't return to any use once they got to the US. Addiction changes the brain. So as addiction progresses, there's a large spike in dopamine release from substance use. Remember, we talked about substance binds to a specific receptor in the ventral tegmental area, and you get that large release of dopamine in the nucleus accumbens. Well, when the person continues to use substances and they're getting these massively high spikes of dopamine, what happens is if there's always a lot of dopamine there, then you don't need many dopamine receptors anymore. So with time, there's a down regulation specifically of something called the dopamine D2 receptor within the midbrain. So as the dopamine receptors decrease, more and more dopamine is needed to have the same effect. So, tolerance, well, part of tolerance is due to that. By the time people with opiate addiction come to me, I hear the same thing all the time. I don't use anymore to get euphoria, to get high. That's long gone. I use to stay out of withdrawal. So those D2 receptors are down so much that they're not getting that euphoria anymore. They're just maintaining at that point. There's something called the pleasure threshold. The pleasure threshold is the amount of dopamine that you got to get released to feel some kind of pleasure. So as the dopamine receptors decrease, the pleasure threshold rises. And these changes in the brain can persist for a long period of time in recovery. So it can take 6 to 18 months of abstinence for the brain to kind of get back to its normal homeostasis. So until that happens, people in early recovery feel absolutely horrible and nothing brings them any pleasure. They used to like to play the guitar. They come out of rehab. It's 3 months later. They have no interest in playing the guitar. Why? It doesn't give them any pleasure. The little dopamine spike that would cause isn't enough. So the condition is called anhedonia, lack of pleasure. Imagine feeling absolutely horrible for 18 months, but your brain knows it can feel normal by doing one thing, and that is to pick up again. This is why these relapse rates are so high, 70% within a year of getting out, most in the first 90 days. So this is kind of a crude drawing that I made, but in sort of you and me in average state, we have this pleasure threshold. So if we can get our dopamine levels above that, we get some kind of enjoyment, some kind of pleasure, some kind of euphoria. So in the average person, there are things in life that bring us joy. So we go on vacation, we get a job promotion, a walk on the beach, a hike in the woods, a day with your loved one. It doesn't matter. These things will cause a little bit of dopamine release. Where's my cursor? There it is. So we get a little bit of dopamine release and we get some pleasure out of that because we crossed that pleasure threshold. So it's like, wow, that was a really fun vacation. I think I might do that again. Or I really enjoyed that walk on the beach. I think I'm going to do that again. But with addiction, as I'd already mentioned, substance use causes this massive release of dopamine in that nucleus accumbens. So they pick up a substance, cocaine, alcohol, heroin, fentanyl, whatever, massive release of dopamine. Well, as you are continuing to flood the brain with this much dopamine all the time because the substance use continues, what happens is, I mentioned those dopamine receptors begin to drop. And as those dopamine receptors drop, more and more dopamine is needed to get the same effect. So what has happened is our normal pleasure threshold has then increased. And it's going to stay increased for a pretty long period of time in early recovery. So in early recovery, you go on that vacation, it's not going to cross that pleasure threshold. Life is just not rewarding anymore. So do we have any evidence that through chronic drug use that there's that downregulation of those dopamine receptors? Yeah, we do. There's a lot of imaging studies. This is, again, a PET scan. And this is a PET scan that's tagging those dopamine receptors, those D2 receptors. So if you look at the control patient, lots of dopamine receptors here in the midbrain, reward pathway. If you look at the person with addiction, much more diminished activity, meaning less of those dopamine receptors. They've been downregulated. I want to talk a little bit about the role of chronic and severe stress in addiction and its role in relapse. So when I talk about chronic severe stress, I'm not talking about, oh, I can't pay the electric bill this month. this month. I'm talking about years of trauma. And that kind of persistent stress alters the brain. And it alters the brain in some ways to mimic addiction, which we'll talk about in a second, and alters the brain to set somebody up for addiction. So it's been shown about 1 out of 4 people with addiction has a history of chronic severe stress prior to the onset of addiction. So chronic stress results in several things. So chronic stress results in increased release of corticotropin releasing hormone. So we have a pituitary gland in the base of our brain, releases a lot of different hormones. One of them is corticotropin releasing hormone. And then that hormone then goes to our adrenal glands and releases cortisol. So these chronically stressed or traumatized patients have high levels of corticotropin releasing hormone, high levels of cortisol. We know that high levels of cortisol causes a lot of medical problems. It messes up your lipids, high cholesterol, high triglycerides. It's a risk factor for coronary artery disease, many others. High levels of corticotropin releasing hormone results in downregulation of the D2 dopamine receptors, and therefore a rise in the pleasure threshold, just like addiction, just like what we looked at with that pleasure threshold rising with chronic drug use. Patients with chronic stress have a high pleasure threshold as well, which means that they don't find much joy in life. So those with that chronic stress are more susceptible to addiction due to the fact that if they use a substance, they get a high spike in their dopamine levels. And perhaps for the first time in their life, they hit that pleasure threshold. They will tell you, I felt normal the first time I used. I've heard this many times through many interviewing of patients that their whole life they felt depressed, that sort of anhedonia. Their first time they drank, they're like, is this what normal feels like? And to them, it is. But you can see what a setup that is for the future risk of addiction. What about, so if it's 1 out of 4 people with addiction that have that past history, what about the other 3 out of 4? Well, we know addiction results in stress. You get addicted, you get arrested, the family leaves you, you lose your job, get foreclosure on your house, whatever. So the actual addiction results in problems that leads to stress. Then the stress causes that release of corticotropin releasing hormone and further rises the pleasure threshold, and therefore more substances are needed and the addiction progresses. So kind of to summarize those two things, those with chronic stress are a big setup for addiction. Once they develop addiction, it further increases stress. Or those with addiction, that leads to stress, and stress then progresses the addiction. So it's kind of a vicious cycle. So I want to talk a little bit about factors that are involved in relapse. So a big one is re-exposure to any addicting drug. And it doesn't have to be the drug that that person originally was addicted to. So there seems to be a tight connection between those who use crack cocaine and alcohol. So typically they'll use crack cocaine, they get too stimulated, they'll use alcohol to bring themselves down. But they view crack cocaine as the problem. Perhaps they go to treatment, they get into recovery, they've been absent for a few months, and they view alcohol as, well, that's not really a problem. I just use that to bring myself down, but it's not a problem. It's the crack cocaine that's a problem. So they begin to drink. Inevitably, probably the first night that they drink, they'll return to crack cocaine use. So the relapse was triggered by another substance. Other things that I see very commonly is sort of that connection between opiate addiction and alcoholism. And so patients may have had a past history of opiate dependency, and they get abstinent, maybe through treatment. And at some point later, they pick up alcohol because alcohol was never a problem for them. It was just the heroin they were using. Well, sometimes that'll lead them back to heroin, but frequently it just keeps them on the alcohol. And then they're coming to me a year later because they have alcohol dependency at this point. I remember a a young girl that came to me for treatment for addiction, and I was getting a family history, and she talked about her father, and she's like, well, my dad used to be an addict. I said, okay, like what was he using back then? Well, he was using heroin. And what about now? She goes, well, he just drinks, but it's not a problem. And then he picked her up from her appointment, and he smelled like a brewery. So my guess is he's probably a daily heavy drinker, probably meets all the criteria of alcohol dependency, but he had that past history of heroin addiction. This re-exposure to substances can sometimes be our fault, meaning medical. So somebody goes through they're in recovery from an opiate addiction, they have some kind of major surgery, you have to put them on opioids, but that reactivates that reward pathway and frequently may lead to a relapse then. So you have to weigh risk versus benefits. So the guy that sprained his ankle, it came in the ER, okay, put a splint on him and give him some ibuprofen. The risk of addiction might be too great for opioids. The person who's just gone through major abdominal surgery but has a history of addiction, well, risk versus benefits. I mean, they need pain control. We do not want to deny care to people with addiction. We just have to be cautious with the care. So they have this major abdominal surgery. They got to have some post-op opioids for pain management, most likely, depending on the surgery, but they're now at a risky period. They've just kind of tickled their reward pathway. Sometimes you'll see a relapse a month or two later, and it's not coincidental. It was probably tied into that stimulation of the reward pathway. So I've had patients that I've treated and for maybe a long period of time, and I've discharged them from treatment because they're doing good. I always tell them the same thing. If you ever need surgery, you got to call me. And if it's elective surgery, I want to meet you in the office before the surgery, and we're going to talk about a game plan so that we don't fall into this relapse. If it's emergent surgery and it just happens, you call me after the surgery. There's nothing I can do to help prepare for this. All right, so re-exposure to addicting substances. All right, one risk factor. Another is stress. I mean, we talked about that, that stress and corticotropin relieving hormone and so on. So a lot of people I interview that have had a little bit of clean time and relapse, find out what's going on in their life, something very stressful. And another risk factor is environmental cues, or we call them triggers. So these are the people, places, and things that in the past were associated with their use. And as I sort of alluded to earlier, that this is mediated by the neurotransmitter glutamate, which plays a major role in memory. And a lot of this is stored in the amygdala, the emotion center of the brain. So if you have somebody who has become opioid dependent and they go to their doctor and they get their OxyContin prescription, and so a memory is being formed there, like, oh, doctors are good, doctors give me prescriptions and these prescriptions are good. And then they go to a pharmacy and it's like, pharmacies are good, I get my meds there. And then the pharmacist gives them this bottle, this little round orange bottle, and it's got pills in it. And that memory, oh, these orange bottles, these are really good things. And all this is being stored in the brain, and even shaking the bottle, the sounds of the pills clackling in there, they remember that's stored in their memory. And eventually maybe they get treatment, they get into recovery, and they have to see a doctor for something else. They're kind of tickling their brain at that point. Those memories, oh, doctors are good, you get prescriptions, pharmacies, orange bottles, those are all good. That's a trigger for them. Or they have to go to the pharmacy to get something else. And but then the brain remembers, pharmacies are good, and I get these little orange bottles there. So this is all ingrained into their brain. And it can take a long time in recovery before those things become less important to them. So environmental cues are a factor in relapse. Now, I'm not really going to go much into treatment in this talk because some of my other talks will be doing that much more extensively. But I just kind of want to make 2 points. So we got this little drawing down here. So there's our reward pathway, ventral tegmental area, nucleus accumbens will be around here, dopamine's being released. And remember, that connects to the prefrontal cortex. So, we got the primary defect being the reward pathway. A consequence of that is diminished activity in the prefrontal cortex. So most of the medications that we use to treat addiction work at the level of the midbrain, but they don't do anything for the prefrontal cortex. Counseling works at the level of the prefrontal cortex. And this is where all those cognitive distortions originate from. So the typical things, thinking errors that we see in addiction, denial, the rationalization, the minimization, the blaming, all that is coming from this area. So the best treatment approach for somebody with the disease of addiction may be both medications working at the reward pathway level and counseling working at the level of the prefrontal cortex. So I'm not going to go into any more than that in regards to treatment today. Get a drink. So sort of the defining characteristics of addiction: loss of control of substance use. They can't stop. They can't control it. Cravings. So a strong desire to use when they're not using. Continued use despite negative consequences, and those cognitive distortions we talked about up here, primarily denial. So as I mentioned earlier, when we were talking about that Vietnam study, so that Vietnam study used the old DSM-4 criteria, which was substance abuse and substance dependency, and view dependency as having the disease of addiction. Not everybody who misuses substances has the disease of addiction. Some of them have abuse. So let's look at the DSM-4 criteria first, the old one. So there were 4 criteria for substance abuse. So what is substance abuse? A maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by any one of the following 4 within a 1-year period of time. So, what are those 4 abuse criteria? Recurrent substance use resulting in failure to fulfill major role obligations at work, at home, at school. Number 2, recurrent substance use in situations which is physically hazardous. So drinking and driving your tractor around the yard, drinking at work and using power tools, those kind of things. Number 3, recurrent substance-related legal problems. So DUI arrests or disorderly conduct, assault charges, domestic violence, and so on. Now, remember this one, recurrent substance-related legal problems. Just kind of put that in the back of the head because I'm going to talk about that in a couple of minutes when we go to the DSM-5. And then the 4th criteria for substance abuse: continued use despite having persistent or recurrent social or interpersonal problems, which are caused by or exacerbated by the use. So 4 abuse criteria, one of them gets you substance abuse diagnosis. We have, back then in the DSM-4, 7 dependency criteria. So view dependency as the disease of addiction. So what is dependency? A maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by 3 or more of the following 7 criteria within a 1-year period of time. So number 1, tolerance. Tolerance is very physiologic. So it kind of makes sense that might fall under the disease of addiction. So tolerance means you need more and more of that substance to get the same effect. And we sort of already talked about part of that reason is because of that diminished D2 receptors, and therefore more dopamine is needed to get the same effect. So tolerance, another physiologic criteria, withdrawal. So withdrawal is very substance dependent. Not all withdrawal looks alike. There's a cluster of withdrawal symptoms that are typical for opiate withdrawal. There's a cluster of symptoms that are typical for alcohol, benzodiazepine withdrawal, other symptoms that are consistent with marijuana withdrawal. Certainly those symptoms are much more subtle, and somebody may not recognize that what they're going through is THC withdrawal, but they do recognize that if they use more marijuana, they feel better. So tolerance, withdrawal. The substance is often taken in larger amounts over a longer period of time than intended. That's classic loss of control. There's a persistent desire or unsuccessful efforts to cut back or control substance use. Again, loss of control. Number 5, a great deal of time is spent in activities necessary to obtain the substance, to use the substance, to recover from its effect. What that means is the person with addiction's life is beginning to revolve around substance use. Number 6, important social, occupational, or recreational activities are given up or reduced because of substance use. So they're giving up everything, their family, their jobs, their education, whatever. I mean, how many people have you maybe worked with a past history of addiction that, they were in college, but they didn't make it past a couple semesters because the substance use became primary, and studying and staying up all night for studying for exams, that fell by the wayside. And then the 7th criteria for dependency is the substance use is continued despite knowing or having persistent physical or psychological problems that is either caused by the substance use or exacerbated by the substance use. So you got those 4 abuse criteria, the 7 dependency criteria. That's the old DSM-4. But then a handful of years ago, they evolved to get the DSM-5 criteria. And now they call it not substance abuse or dependency, they call it a substance use disorder. And as a substance use disorder, it's more of a spectrum because you can have a substance use disorder mild, moderate, or severe. And the way they came up with these criteria is they took the 4 abuse criteria and the 7 dependency criteria and they jammed them together. They removed that one that I told you, remember, about persistent legal problems due to substance use. So they took that one out and they substituted in that cravings. We do know that cravings is part of the characteristic of addiction. So the 4 plus the 7, put them together, take out the legal problems, put in cravings, and then they reworded some of the ones, but basically they have kind of the same flavor. So now we have 11 criteria for a substance use disorder. So let's look at those 11 criteria. So consuming the substance in larger amount for a longer amount of time than intended. Persistent desire to cut down or regulate the use. The individual may have unsuccessful attempts at stopping in the past. That's loss of control. Spending a great deal of time obtaining, using, and recovering from the effects of the substance. Experiencing cravings. There's that new one that was put in there. Experiencing cravings, a persistent desire to use the substance. Substance use impairs ability to fulfill major obligations at work, at school, at home. They lose their job, they drop out of college. Continued use of the substance despite it causing significant social or interpersonal problems. Reduction or discontinuation of recreational, social, and occupational activities because of substance use. As I mentioned before, the world begins to revolve around substance use, and those other things are less important because the reward pathway doesn't believe that they're as important. It views substance use as the important thing. Recurrent substance use in physically unsafe environments. So, that could be that DUI. Persistent substance use despite knowledge that it may cause or exacerbate physical or psychological problems. And they kept in there the tolerance, needing more to get the same effect, withdrawal we talked about. So that's the new 11 criteria for the substance use disorder, the new DSM-4. If you have 2 or 3 of those 11, you have a substance use disorder mild. If you have 4 or 5 of those, you have a substance use disorder moderate. And if you have 6 or more, it's substance use disorder severe. Now, some studies have looked at that there's a high correlation between having a substance use disorder, moderate or severe, and having the old criteria of dependency, substance dependency. And why wouldn't there be a high correlation? The criteria look very, very similar, slight changes, that's all. Now, there are some in the field of addiction medicine that do not like the new substance use disorder criterion. And honestly, I'm one of them as well. And why is that? Why do I not like substance use disorder, mild, moderate, severe compared to substance abuse and dependency? Well, because with the new criteria, it looks at everybody who uses substances abnormally as just being in a spectrum. And so these people are using them less abnormally, these people are using them more abnormally, but they're kind of all the same, but some are, not as bad as the other. And that implies that everybody who uses substances abnormally has the disease of addiction, which we know isn't true. How do we know that isn't true? We looked at that Vietnam study that, the 34% were using heroin. Only 1 to 10% were using heroin once they got out and returned to the States. So that's why a lot in the field, like the old abuse, which we look as sort of a behavioral thing, and dependency as the disease of addiction. But I'm stuck with what I got. So we now use a DSM-4. I just recognize that even though it's a spectrum, not everybody on that spectrum is the same. Some have the disease, many may not. So a couple summary slides here. So we know that addiction is a brain disease resulting from the expression of certain genes. So I sort of talked briefly about twin studies for people with alcohol dependency and how separating identical twins early in life, you pretty much saw the same end result in both twins. It's just the one that grew up in the non-drinking environment had a later onset of the disease. Actually, those same kind of twin studies looked at those with non-identical twins. So they don't have the same DNA. You separate one from the family, grows up in a more stable non-drinking environment. Well, when they're non-identical twins, you don't see that high correlation that if this one developed alcohol dependency, this one definitely did too. There's not a high correlation because they don't have the same genes. So addiction is brain disease resulting in expression of certain genes. It's a chronic disease. It's a progressive disease. It's a fatal disease. It tends to relapse. Remember, 70% of patients out of rehab are going to relapse in the first year. In susceptible individuals, substance use results in brain adaptations where the midbrain views a substance as essential for survival. And the resulting behavioral changes you see in those with addiction are a result of the prefrontal cortex being suppressed. So addiction's not a choice, it's a neurobiologic disease resulting in loss of ability to make good choices. Chronic stress results in the same changes in the brain as addiction and is a risk factor for the future development of addiction and relapse. So we talked about that corticotropin releasing hormones being high in people with chronic stress, and that causes the downregulation of the dopamine receptors, which results in a raise in the pleasure threshold. So these people may have anhedonia throughout their life, and that first use of a substance is where they, for the first time, feel normal because they were able to get their dopamine up and above that pleasure threshold. Addiction treatment may involve medications that work at the midbrain and counseling that works at the prefrontal cortex. And some of my future talks, we're going to talk specifically about treatment, specifically medication-assisted treatment. And we also looked at the evolution of the DSM-4, the abuse dependency criteria, to the DSM-5, substance use disorder, mild, moderate, and severe. So I'm going to conclude with this slide. You may have known that a couple of weeks ago that we had that total solar eclipse. And so me and my wife and some friends drove up to New York because we wanted to get into that path of totality. And I brought my telescope. So these are some pictures that I took of the eclipse. So the one on the left, you can see the moon cutting out the sun. This was totality. You can see some solar flares there. And then as the eclipse came to an end, the moon's moving off. So with that, Rachel, I'll kind of turn it over to you.
Thank you so much. Boy, that's a pretty spectacular set of photos that you've got there.
Thank you.
I would like to know now if anyone has any questions. You can either unmute yourself and ask or put them in the chat if you would like. I currently don't see anything here. Let's see here. We do have one point here from Dr. Cassidy, Dr. Renee Cassidy. Regardless of the label abuse or dependency, disease of addiction or not, isn't the utility of the DSM-5 versus SUD criteria that it applies to those experiencing adverse effects? It avoids medicalizing behavior that isn't causing problems.
I guess that's a valid point. And by the time patients come to me, it doesn't matter whether I'm using a DSM-4 or 5. They've already declared themselves as having the disease of addiction. So I mean, I don't have to formally go through the DSM-4 or 5 and give them that label. But I mean, that is a valid point. And what I'm seeing when patients are coming to me is that long history of behavioral problems. I don't view the behavioral problems as the primary problem, but a consequence. Nonetheless, I will say we have to be held accountable. So if the person has had criminal activity as a result of the addiction, I understand it. But that being said, accountability is still necessary. Accountability is part of recovery.
Understood. Does anyone else have any questions?
Yeah, I have a quick one.
Dr. Colley?
Yeah, hi. What realistically or clinically is there really any difference in treatment the patient who might be diagnosed with abuse versus dependence? Because the problem at our clinical level in primary care is, how do you know? Because it's really based on history. So if the abuse patient can cognitively stop drinking and the dependent one can't, we don't really know which is which. And so ultimately, you know, how do we treat the patients?
Okay, yeah, good point. So if the person has abuse, in general, they will stop their substance use when there's a compelling reason to stop. So sometimes we as physicians have to help them to see those compelling reasons, such as, well, geez, you know, your liver function tests don't look good, you know, they're kind of elevated. Or we might have to point out to them how their substance use has been affecting, you know, their marriage or their family life, their relationship with the kids. So we might have to kind of probe into some of that stuff. And like I said, if there's a compelling reason to stop, those with abuse may just stop. Counseling can be helpful with people with abuse, primarily because counseling is going to start to look at that stuff and point that stuff out. Those with dependency are going to need a lot more treatment and probably more intensive treatment. If they have dependency with physiologic dependency, meaning withdrawal, I mean, first things first, they need to be detoxified, whether that means the inpatient treatment or, you know, I do a lot of that in the outpatient setting too. So they may need detoxified. Once that happens, these patients might be good candidates for very intensive counseling and medication-assisted treatment. I'm not giving medications like, say, Vivitrol for an alcohol use disorder to patients with alcohol abuse. I help them to stop drinking by exploring how their alcohol use is affecting their lives. But with those with dependency, they're just going to need a lot more treatment, a lot more intensive treatment, a lot more prolonged treatment. And as a primary care physician, medication-assisted treatment might be a role that you would play, as well as engaging them in some kind of counseling. Now, initially, it may be a low-level counseling, and then the patient may continue to not do well, and then, you know, may need a higher level of treatment or maybe even residential treatment, but they just need more treatment. How do you know the difference? I've been doing it for a lot of years. If it walks like a duck and quacks like a duck, it's probably a duck. So it's basically going through the history and maybe looking at some of that physiologic stuff, such as tolerance and withdrawal.
But there's no radiographic or chemistry data you can use to determine the difference.
Not on a clinical level, certainly on a research level, some of that PET scan stuff we did, but yeah, that's all research. So not on a clinical level. It's, it might be okay to overtreat a patient as opposed to undertreating a patient, although a lot of times patients are resistant to any kind of treatment. If you have somebody that really doesn't have the disease of addiction, but they're drinking a lot, and you start them on medication-assisted treatment, you're probably not hurting them. But if they have the disease, you may be helping them significantly.
Thank you. Very good.
We have one other question here. Do you think that the relatively low number of Vietnam vets, 10%, that developed dependency is function or duration of use? I would think over time, any use becomes more frequent and leads to higher rates of SUD.
So that wasn't looked at in this study. So they didn't look at of those 14,000. Okay, these ones used for a year, these ones only used for 6 months. So it wasn't looked at. But what I will say, physiologic dependency doesn't equal the disease of addiction. So I can take anybody and just pump them full of opioids for a long time and then stop it, and they will have opioid withdrawal. But that doesn't mean they have the disease of addiction. So they'll have opiate withdrawal. If you then help them through that process, detoxification, what will happen is once they've gone through that, they will no longer have cravings to use. They'll no longer have that desire or compulsion to return to use. Those are the characteristics of the disease. So of those who had in Vietnam, ongoing opioid use, which I can't say anything about duration, some of them may actually had that physiologic dependency, but once they got through that, the compulsion to return wasn't there.
Do we have any other questions for Dr. Davis this evening?
There was one other question that was posed. They were asking if there are more meetings to discuss. When are the meetings for the dates for the discussion of the addiction treatments? And
I can actually give that information. So we will be having a presentation on medication-assisted treatment for opioids on May 23rd. We will have a presentation, these are also with Dr. Davis, on medication-assisted therapy with regard to alcohol use on June 6th. And then there will be a lecture on stigma on June 20th by a different presenter.
thank you.
Any other questions? Well, I'd like to thank you all for joining us. And Dr. Davis, thank you for a wonderful presentation.
Thanks for having me.
Excellent information, and I look forward to listening to the next one.
Thank you.
Thank you.
Superb. Thank you.
Terrific. Okay, I think we are done for this evening then. So I will have you, Janet, stop recording, and we will see you all hopefully next time.